I appreciate those efforts. I think it's been a long-standing issue. Let's put it this way. I mean, there are many counties that are doing an outstanding job on behavioral health, but there's also, unfortunately, I think we've seen inconsistencies. We also don't have good data, and I appreciate, and I mean that, and I realize that, for example, the CMS issue was, some of it was technical issues, et cetera, but I think it underscored the fact that while certainly we have many outstanding county programs, that we also are a state, and we do need to, that every person who lives in the state of California, and not just ones in particular counties, deserve to have good access to mental health. And in some ways, I would just say that Prop 63 has certainly been a tremendous boon, but sometimes I think people get too distracted in just looking at the Prop 63 funds and not paying enough attention to how we're using our Medi-Cal funds, which actually is a very substantial part of the resources we put into mental health. And we need to have statewide standards. Now, I realize, different counties are different. They have different needs, and we need to have that flexibility. But there has to be accountability, too, on a statewide basis. And so I hope that you can continue to keep us appraised of the efforts that you talked about and the timelines and the resources necessary to be sure we have those in place so that there can be accountability across the state for our behavioral health system, particularly on the Medi-Cal side. Thank you.
Thank you. Okay. I think we're on 16.
Right. So the department did put forward a proposal in regards to increasing access to the behavioral health continuum of care infrastructure. Prior to the pandemic in California and nationwide, really seeing an increase in regards to overdose deaths, suicides, and an increase of need for mental health, illness, and substance use disorder services. And the pandemic really just accelerated those trends. We do know
Director,
that—
if I could stop you 1 second, because Senator Melendez, did you have a question on the last issue? I'm sorry, I forgot to call on you. I didn't see your hand up. Okay. Okay. And Department of Finance on the last one.
Yes, Ileana Ramos, Department of Finance. I just want to loop back to Senator Pan's question on the Office of Inspector General audit settlement and the status update of that. So there was a report submitted that required the California to repay $180 million to CMS for unallowable county specialty mental health claims. The state paid for it in December 2018, and we have been recouping county funds to support that. The initial intent was to recoup that over a 4-year period. We were able to recoup that for 18-19. In 19-20, we were unable to recoup that due to the limited realignment funds, but we anticipate being able to recoup starting in 2021.
Okay, thank you very much. All right. Now we're back to the number.
Yes. So in California, we see that we have inpatient psychiatric bed capacity is about 21 beds per 100,000 residing in the county. However, experts estimate that really capacity should be at about 50 per 100,000 in California. And so we currently only have around 2,600 mental health treatment beds. With the proposal before the legislature for consideration, we're proposing $750 million one-time general fund dollars over 3 years, where we would allow for competitive grants to increase that behavioral health continuum infrastructure. It would be available to both counties and tribes. We would start the competitive process in January of 22. The intent behind the grants would be to acquire and or rehabilitate existing real estate assets across the state of California. Given the public health emergency, we do know that it is an opportunity where certain buildings, property will become available, and maximizing that opportunity to convert that into behavioral health infrastructure across the state of California. With the $750 million, we are assuming that we would increase about 5,000 beds. So a pretty sizable increase in regards to that footprint. We are proposing that the services be across the full continuum, which would include all the way from crisis stabilization, residential, as well as community-based and outpatient mental health services, really allowing for us to, in the future, seek an SMI SED IMD waiver from the federal government, similar to what we have on the substance use disorder side, to draw down federal funds for IMD stays, which would allow those funds to come in and fund additional access to behavioral health services in California. And this allows us to demonstrate to the federal government that California is very committed to expanding our mental health footprint across the state of California, which will be required to be able to receive federal funds for those stays. I would also just note that we would require that the county or tribes applying for these funds provide a local match. We are currently proposing a 25% local match with this proposal, and that would include them being able to use property, for example, on that local match. In addition to state general fund, MHSA, or other funds available for that local match, we want to work very closely with our county and tribe colleagues in regards to that, to ensure that's not a barrier to accessing these funds, but an important part of the proposal. We also, given the fact that we are trying to increase access to the continuum, would be looking for a commitment from the counties and are currently proposing a 30-year commitment of those funds to secure access to those services in the long term. In order to ensure that we are closing behavioral health continuum gaps across the state of California, we will be conducting a gap analysis and assessment to be able to inform the award grants across the state to ensure that we are closing gaps in certain parts of the state where we don't have enough access to outpatient and community-based mental health services, and to really grow that footprint. Also, we have reached out to CAFA to meet and learn from their experience. However, we do believe it is important for the Department of Healthcare Services to oversee the implementation of these funds to ensure that the facilities are meeting our requirements, that we're closing continuum gaps. We are the ones who license and certify these entities, and we do think it is the best department to oversee these funds. And happy to answer any questions you may have.
Department of Finance?
No comments or questions at this time. Thank you.
LAO?
Thank you, Senator Eggman. Corey Hashida with the LAO. Just want to bring to your attention that our office actually published an analysis on our website discussing this proposal, and I'll just give some brief remarks touching on some of the main points that we raised. First, we would just note that there are some substantial details related to this proposal that remain under development. These would include, for example, what specific milestones counties would have to meet in order to receive disbursement of funds, or how the program would be evaluated. It's also our understanding that for this proposal, the administration intends to rely on budget bill language rather than trailer bill language to establish the program. We have concerns about this given that budget bill language typically lacks specificity and detail when compared to trailer bill, and we find that the legislature's role in providing oversight of these funds may be significantly constrained under the budget bill approach, and so we're suggesting that the legislature adopt trailer bill to sort of ensure that it has a sufficient role in the process. Next, we don't raise any issues with the concept of expanding behavioral health treatment capacity statewide. Certainly, this is a very pressing need across the state. We also find that this one-time investment is likely a good use of the state's significant one-time windfall. We do find that there's enough overlap between this program and prior state grant programs, including ones through CHAFA, as the administration just indicated, for behavioral health facilities to provide an opportunity to apply lessons learned. For example, the investment in the Mental Health and Wellness Act of 2013 established a grant program under CHAFA to provide funding for facilities for crisis stabilization units, which is one of the facilities that this proposal would also fund. And to avoid delays in disbursement of funds under that program, the state sort of made the option available for nonprofits or corporations to apply for funds directly on county's behalf, and sort of that sort of like accelerated the process for getting funds out the door and helped avoid delays in the program. We would also flag that this proposal has significant interactions with a couple of other major budget proposals in the budget. First, as noted by the administration earlier, the CalAIM Medi-Cal proposal includes a commitment to pursue a federal waiver opportunity to access federal funds for services in institutions that normally Medicaid will not pay for. And as the administration noted, in order to get this waiver approved, the state would have to demonstrate a commitment to building out community treatment options to sort of avoid a disproportionate incentivizing of institutional placement. So the legislature may want to consider its stance on that CalAIM commitment and weigh that against the potential benefits of this proposal. In addition, there's a proposal in the Department of State Hospitals to expand community-based options for individuals who are incompetent to stand trial. And the legislature may want to ask the administration how it's sort of coordinating these two efforts together. In addition, the administration is presenting this proposal as part of its overall homelessness efforts. And while there is certainly overlap between individuals experiencing homelessness and those with significant behavioral health needs, we find that a targeting of funds specifically to individuals experiencing homelessness who also struggle with behavioral health issues would be a more direct way to sort of get at the overall homelessness issues that the state faces. And finally, as the administration mentioned, the counties under this proposal would be required to sort of put up a local match, and the legislature may want to seek additional details just sort of on how that 25% match level was determined, and in order to sort of assess what counties' capabilities of putting up that match would be.
Okay, thank you very much. Yeah, I guess that would be one of my first questions is we have so much going on in this space. Did you talk with Katja on lessons learned from the Mental Health Wellness Act that they're already doing? And why stand up a whole new program when we're in the midst of all this reform versus just going with the agency that already has the experience in doing this and can more quickly stand it up and just continue forward?
So we have reached out to CAFA to hear and learn from their experience. However, do feel like given the responsibility of the Department of Healthcare Services to oversee the behavioral health continuum, as well as in partnership with our counties in regards to that, that it be our responsibility to ensure that the funds are going specifically to closing those continuum gaps across the state of California. And to ensure that there is a commitment, for example, to ongoing operational management funds to ensure that we have from a service delivery point of view, that moving forward, it's larger than just the facilities and the acquisition of buildings and the rehabilitation. It really is focused on the fact that we would want to ensure that the funds are going to services that would be licensed and certified by the department, that is coordinated seamlessly with us upon the allocation of those funds, and that we are being strategic in regards to closing those gaps to ultimately really increase and have a clear insight into making sure the dollars are not just allocated out or that we're really closing continuum gaps that we see in California.
I guess I would agree with the second part, maybe not necessarily the first part as much, because I think just that is a ton of new functions that you would be taking on with that. And then the question the LAO asked about counties and this 25%, how do we come up with that figure, and have we assessed the counties that will be able to match that?
So we have looked at a number of previous programs in regards to what has required a local match to see the variation of the percent, really given the responsibility that the counties bear in regards to behavioral health services in California, specifically within the Medicaid program. We did think it was important to have a local match and commitment to the funds provided. So we don't have an exact in regards to the 25%, though we do think it is important to have the local match. Given that, though, we are trying to be and have already had conversations with CBHDA and CSAC regarding flexibility around what that local match looks like. It could include, county general fund, MHSA funds, other funds. They could also match it with the property cost, as well as, we will be willing to work with counties on the flexibility of the local match, but do think it's an important part regarding the responsibility counties currently bear for behavioral health continuum services.
Thank you. Dr. Pan? Okay, thank you very much. We'll be following this one with great interest. Number 17, please.
Of course. So within the governor's proposed budget, we are proposing to invest $400 million total fund, $200 million general fund over 3 years to increase the number of kinder through 12 students receiving preventive early intervention behavioral health services offered by school-affiliated behavioral health providers. The funding would be distributed via incentive payments through our Medi-Cal managed care plan. So essentially, the department is proposing to have a robust incentive program through managed care to really look at increasing access to services. It would pay for infrastructure, partnerships, and capacity building. We do allow for a variation in regards to the types of incentives. It could include, for example, three-way contracts between our Medi-Cal managed care plan, counties, and school districts. It could pay for planning services for how do we increase access to behavioral health services in schools. It could play for telehealth portals or billing portals in schools to be able to increase access to those types of services. I would just note the proposal is specifically for infrastructure, capacity building, et cetera. Services can be billed directly and separate outside of this. The main reason we are proposing it go through the Medi-Cal managed care plans is our Medi-Cal managed care plans are responsible for the non-specialty mental health services provided to children, which is dominantly children are going to be needing non-specialty mental health services. We know that our county partners have made large inroads in regards to partnering with school districts to get specialty mental health services in place. And we are really wanting to ensure that we're looking across the full continuum where we pay our Medi-Cal managed care plans to provide the non-specialty mental health services so that all children can receive behavioral health services in schools. And we think that is really important to maximize. While our current focus is also focused on increasing access to Medi-Cal behavioral health services in schools, we do hope that by putting in the infrastructure like the billing systems, the data sharing systems, the technical assistance that's needed for the school districts to be able to understand how to better bill Medi-Cal services and interact with managed care plans, that we'd be able to increase access to all Medi-Cal services on school-based services in the schools. We also think that by investing in these infrastructure and capacity building with school districts, that it would impact non-Medi-Cal kids and really allow for, while Medi-Cal is 50 to 55% of all kids are on Medi-Cal, there are non-Medi-Cal kids that could greatly benefit from school districts being able to bill and provide services to those other payers in the school district. So we think that is an outcome that would greatly benefit all children across the school. We do also know that this is, we're hoping this will be braided funding and collaborate with other kind of funding streams that are flowing in this way, whether that's MHSA or other dollars that the school districts have. We plan on providing extensive technical assistance to make sure that it is complementary across the Medi-Cal managed care plans, the counties, LEA BOP, as well as other MHSA funds. But we do think it is an important investment to make to ensure we're increasing access to Medi-Cal services in schools. To be able to do this, DHCS is requesting limited term resources equivalent to 12 positions with the funding expenditure of $11 million total fund to be able to implement this particular proposal. And happy to answer any questions you may have.
Thank you. Department of Finance?
No comments at this time. Thank you.
LAO?
Thank you, Senator Eggman. Corey Hashida again with the LAO. Again, we recently published an analysis of this proposal on our website, and I'll just sort of give some brief remarks touching on some of the the main points that we raised. First, we would just note that similar to the last proposal, the Continuum infrastructure proposal, there are some substantial details related to this proposal that, to our understanding, are not sort of fully fleshed out at this moment. This would include, for example, the specific allocation methodology that would determine how the incentive payments would be distributed to managed care plans. And our understanding is that the administration is also proposing to rely on the budget bill process to establish this incentive program as well. And we suggest the same sort of like trailer bill approach that I discussed earlier in the Continuum proposal. When it comes to the intent of this proposal, we don't raise any issues with the concept of increasing managed care plans' footprint in schools. We do find that it's unclear whether the amount provided in incentive payments will actually induce managed care plans to invest in these partnerships. And the legislature may want to ask the administration how it determined that this funding amount would be sufficient to sort of change plan behavior and induce the desired partnerships being created. In addition, we find that the real challenge with this proposal is going to be navigating the very fragmented behavioral health delivery system. Students can access Medi-Cal behavioral health services through several different entities. It could be a county, it could be a managed care plan, it could be a school directly. And the administration touched on sort of the dividing line between specialty mental health and non-specialty mental health between counties and managed care plans. But which entity is responsible for what service through Medi-Cal can often be determined inconsistently. And in addition, counties may also provide sort of the same services that managed care plans could provide under their non-specialty mental health responsibilities and just use their local funds instead of paying for the services through Medi-Cal. And so all of this is to say that this proposal really highlights the need for the administration to clarify exactly what service gaps managed care plans could fill under this proposal. And it really also sort of highlights the need for a comprehensive state effort, even thinking more generally outside of this specific proposal, to coordinate these different entities together to ensure that A, all the services that students are entitled to through Medi-Cal are being provided, and B, that no duplicative services are being provided by either counties or managed care plans. We would also raise that there are a couple of other proposals in the budget related to student mental health. There's a proposal to provide MHSA funds to support a state grant program to, sort of support county school partnerships. And there's also a proposal to provide Prop 98 funds to schools in order to match county student mental health activities. And so this coordination issue that sort of brings up the coordination issue again and sort of raises the issue that it's sort of unclear how this proposal will sort of interact with those other proposals that are in the budget.
Thank you very much. So Director Cooper, I guess we all I think agree with the idea of increased behavioral health services in schools and to our young people, and I believe this is an attempt to try to provide access and streamline things. But how do you respond to the issue that in some ways it just makes one more level of confusion and potentially duplicative services and not a real clear path about how somebody gets care?
I think what I would say there is that the Medi-Cal managed care plans have a clear responsibility to provide the non-specialty mental health services to children. And while I clearly understand that some counties may choose to use local funds to provide those services, we are already paying the Medi-Cal managed care plans to do this, and we hold them accountable to it in the capitation rate that we pay them. And so it would be more prudent for us, since we are already paying the managed care plans through that, for them to be ensuring that children are getting access to those services. And I think with this proposal, we're trying to look a little bit more upstream in regards to making sure that kids are getting access early. And we do think that there is an opportunity with this to better strengthen the relationships between the Medi-Cal managed care plans and counties, because they do have a shared responsibility for providing mental health services as a whole between the two of them to both children and adults in California. And so we do think that there is still a huge opportunity. For example, Today, within many of the behavioral health services provided in schools, whether through LEA BOP or specialty mental health, it oftentimes is only really provided for individuals with, special education services, or when it's in the IEP, depending on which portion we're talking about. And there are counties who have expanded to the non-specialty side too, even though ultimately that responsibility is the managed care plans. However, we want to make sure that children have access to their full rights under EPSGT and under Medicaid to all behavioral health services and all Medi-Cal services. And so by getting the managed care plans into the schools, while we do need to have better coordination with our county partners, it also allows all of those other non-behavioral health Medi-Cal services to be available for those children in the schools as well. So there is that additional opportunity with leveraging these dollars and putting the infrastructure in place so that school districts can remove those barriers. We've heard for a long time that everyone wants to be in this space, but they can't do it because they don't understand how to bill Medi-Cal. They don't have the data systems to do it. They don't have the billing systems to do it. And so these incentive dollars are really meant to remove those historical barriers that we've heard to be able to get in a space where children can maximize their full Medi-Cal benefit and not just a very small portion, which is currently being provided today.
So if the plans are already supposed to be doing it, why aren't they? And why do we think this incentive is going to be enough to incentivize them?
It's really the pieces I was talking about earlier. It is complex, just to be clear. This is not easy to do. But we've heard, school districts historically have had challenges understanding, whether it's negotiating with the managed care plan, how to bill, having systems that allow for them to bill and be reimbursed for services, et cetera. And so that's why these funds aren't for the services. That's already built into our budget today in regards to the capitation rates going out. This is really to do the actual infrastructure necessary. So if they want to convene, plan school district and county to have a planning process to figure out how they're going to increase, the incentive dollars can pay for that planning effort. It can pay for technical assistance to come in to help move the needle in this space, or to put in a billing system or a data sharing system, or a telehealth portal that could be in the schools that allow for those services to be easier access. So it's really paying for that infrastructure, partnership and capacity building, which is what we have historically heard are the main barriers for both managed care plans who want to get in this space and school districts to kind of get over those humps. Instead of just covering it with local funds, we should be maximizing the federal dollars that allow for us to draw down here, as well as the dollars that we pay our Medi-Cal managed care plans in this space. And so it's really about being prudent with the funds that are in the system and then leveraging it to be able to draw those down. So that's why we think the incentive is good, because it's removing some of those historical barriers for why people have said they have not been able to move into this space.
Thank you. Dr. Penn?
Thank you. I appreciate this proposal. I should just, first of all, preface my remarks by saying that I used to be medical consultant for a school district, and been very involved in school health issues through my professional side, American Academy of Pediatrics, and so I have some practical knowledge, and I appreciate this effort. So I guess my first question is that will you have a mandate for every for the managed care plans who participate in Medi-Cal to contract with every school district in their region? Because after all, the school districts don't want to, and I want to point out, school districts are educational institutions. They don't have, and there's 1,000 school districts, by the way, over 1,000 school districts in the state of California. And maybe some of the larger ones do, but generally, they're not interested in hiring a bunch of staff to negotiate managed care contracts. I mean, let's just be blunt about it, right? So that's not going to have that in. So it actually behooves the managed care companies to and maybe there's a standard contract or something that you develop in conjunction with the Department of Education. But I would say, first of all, is there a requirement that the managed care company have to have a contract of some sort, and you can develop a baseline contract with every school district in their region that's in their service area, so that they are compelled to actually talk to the school districts, because you can't expect the school districts to go try to find the managed care plan. They're busy trying to teach kids.
So with this current proposal, what we have in here is that we would pay a higher incentive to managed care plans that have a higher percentage of school districts in their service
Okay, all right,
area.
okay, so my question is, are you going to require them to?
So with
Yes or
these
no?
incentive dollars, the answer is no, we're not
Okay, all right,
mandating
so-
all of them.
okay.
However, if I could, we are considering within the procurement in the future to ensure that plans that are coming into California understand that the future expectation will be that managed care plans in California do commit to and attest to committing to those contracts to provide services in schools.
All right, so I just want to look at it also from the perspective of the school district, right? So what happens is that for the school district, generally they're somewhat reluctant to say that this set of kids get these services and that set of kids doesn't. Now, certainly they do have differences like free and reduced lunch, et cetera. Although again, when you have a high percentage, so you can imagine a school district that's being serviced by, the two-plan county, a GMC county, or some other, that there are actually multiple Medi-Cal managed care plans. And the problem is that one plan decides to contract, the other one doesn't. And they're sitting there having to sort out and tell this kid who's on Medi-Cal, nope, sorry, we can't do that because your managed care plan didn't. Sorry, you. And so it gets them into this bind, and generally, if they can't get all of them, it's really hard as a school to say, you know what, if you're on Medi-Cal, but you have to be on this plan, then we'll provide these services to you through our school. But if you're on that plan, we're not. And how do you explain to the parents who say, well, guess what? I'm on Medi-Cal, so how come I'm not getting this, but that other kid is? I mean, that's a really hard place to be. And I'm not sure a lot of school districts want to even be in that place. And that's why I'm sort of saying, in some ways, and this actually, from my perspective, speaks to Medi-Cal services school in general, is that unless, basically, you need to be sure any kid who's on Medi-Cal, at least we can draw a line where if you're in Medi-Cal, you're not in Medi-Cal. But if you're on Medi-Cal, there needs to be a universal system for the school district, so they're not sitting there sorting out which plan you're in. Like either you're on Medi-Cal, your Medi-Cal card, or you're not, and you get the service, right? And then there's some systematic way that they're getting, and by the way, they don't want to have different billing processes for different plans, because again, they're in the education space. They don't want to have a bunch of staff saying, I have to fill out these forms for this plan, that form for that plan. And so in fact, if they're, frankly, I would say is that if they're, for school-based services that they might pay for, that you would actually develop a standardized both billing system that's very simplified, and also some sort of because you got to make it really simple at the school district end, because the school district is not a healthcare facility, all right? A clinic, they can develop a whole billing system and so forth because they're providing a whole variety of services, et cetera. A hospital, even a doctor's office, but a school district, we don't want to just have them have a large amount of overhead to figure out how to interface with Medi-Cal managed care plans. So I guess what I'd say is that don't mistake this. I think this is a good idea. I appreciate you providing incentives, but I think in order for it to work, you got to also look at it from the school district's end. So we're going to provide incentives to managed care plans, but for the school district's end, they don't want to sit there and parse out which kid gets this service, which kid gets that service at the school. And I think we do want school-based services. So somewhere at the school-based service level, there's got to be some simplified way to say you're going to get paid for this, that, and that on a fixed fee schedule, so we're not getting paid different amounts for different kids for the same service. And then perhaps the managed care plan has to, so we don't sit there and have multiple some kids on one managed care plan getting services, another one that can't get the same services. So you got a standardized package there. And then of course the managed care plan can also provide, through their own networks and so forth, the non-school based, stuff, because they're going to have referrals to counselors and stuff outside the school, that then they can do their own network or whatever thing. But in terms of their interface with the school, it has to be straightforward and simple. And if we make it too complex and we're talking about having contracts and things like that, that you have to negotiate individual contracts. Maybe there's a standard contract that's fine, but individual contracts and so forth, you're going to the uptake I think is going to be fairly low. You have a lot of missing school districts, and we're not going to achieve the aims we want to achieve. So I really do appreciate that you're making an effort in this proposal, but just from my own experience and my own knowledge talking to school districts, I mean, after all, let's put it this way. When I was chair of the Assembly Health Committee, I couldn't get the HCS and the Department, I had to force the HCS and the Department of Education to talk to each other about LEA. They wouldn't even meet. I finally got a meeting going. I mean, that's the distance that we're still trying to cross, and things are better now. But I think you really do have to look at it from the school district end, because I think that's where your uptake problem is going to be. And if you don't make the managed care companies do something, be able to do something simple with school districts and something that's consistent across, then unfortunately, I think it's not just in incentives. It has to be a set of a sort of a infrastructure that's developed with the user in mind, which is the school district as well, of course, the students in school.
No, I think all your comments are well taken, and things that we have been thinking through on our side, because we do know that some of the largest challenges would be for the school district, especially in parts of the state, Sacramento and San Diego, for example, where there are so many managed care plans. We've been trying to think through concepts for how we set up the incentives for if we do require certain players be at the table to receive the incentives for the points that you've exactly made. I think we're continuing to think through those things, and I think would be happy to continue to brainstorm with the legislature in regards to how to make this as successful as possible, because I think we all agree the need is there. I actually think your idea in regards to standard contract and or pieces is very interesting, and something that we can take back and continue to think through as this proposal evolves and we figure out how we really can move the needle in regards to getting these services in schools.
Okay, well, I appreciate that. As someone who's been in this space, actually, interesting enough, the project I worked on with the school district was actually improving care for children with ADHD, again, a mental health issue. So we actually published our results in the journal. I'd be very interested in what your planning is and your thoughts, and how you're also engaging the education community in this, to be sure that we have, it's not, because you're used to those, I'm sure the managed care companies are used to dealing with you, because you do work. The education community also needs to be engaged to be sure it's workable for them, because you need to have both to make this work. And I'm not saying that you haven't talked to them, but I think that's a very important piece, and I'm very interested in seeing more specifics on how you're planning to roll this out, because I actually want this to happen. So I don't want any of these comments to be viewed as like, oh, I don't think we should do this. But I'm really glad that you're trying to do this, but I also want to see it successful, and I know you do as well. And so hopefully we can share our knowledge and experiences to make that happen.
Yes, we would appreciate those conversations, and we have already done outreach to the Department of Education, and we'll continue to partner with them and look forward to partnering with you.
Thank you very much. Okay. Now I believe we're moving on to issue number 18, Mental Health Services Act flexibilities.
Yes. As a part of the 2020 Budget Act, AB 81 allowed for temporary flexibilities for counties due to the public health emergency. It allowed counties to spend down their local MHSA prudent reserves as opposed to submitting a request to DHCS. It allowed counties to spend clinical service and supports program funding regardless of subcomponents. Allowed counties to use their current approved 3-year plan or annual update if the behavioral health director certifies that they were unable to submit a new plan due to the public health emergency. It also extends the reversion deadline for the unspent county funds subject to reversion as of July 1, 2019 to July now 2021, and allows DHCS to achieve the above through bulletin authority. So this would allow DHCS to expend the current flexibilities for another year, given the ongoing public health emergency, and happy to answer any questions that you have.
Department of Finance? LAO? Dr. Pan? No. I think this makes sense to all of us. Moving on to issue number 19.
So here, DHCS is requesting approximately $1 million for 2-year limited term contractor resources to provide user acceptance testing and technical support to county mental health plans, drug Medi-Cal, and DMC ODS to implement health provider directory expansion. The Health Provider Directory Expansion Project is a department-wide initiative to standardize the format, content, and transmission of Medi-Cal managed care provider network data to the department, and we are expanding that to our behavioral health counterparts. I'm happy to answer any questions.
Department of Finance, anything? LAO? No? Dr. Pan? No? No? We're smart to put these faster ones at the end. Okay. Number 20.
Yes. Here, the department is requesting expenditure authority to implement the assisted outpatient treatment program, expanded statewide beginning January 1, 2021, unless a county chooses to opt out through their Board of Supervisor approval. Participants in the assisted outpatient treatment are individuals with serious mental health illness and who are at risk of institutionalization or would otherwise be served in an institutional setting. And happy to answer any questions regarding this request.
Department of Finance? LAO? Sounds like a fine idea. Dr. Pan?
Yeah, I just want to say it's very important that we fund implementation of an outstanding bill.
All right. 21.
All right. So here, sorry. The department is requesting 4 positions and expenditure authority of approximately $600,000 to implement SB 406 by taking action on complaints against recovery residents associated with licensed facilities that provide unlicensed SUD treatment services. Positions would be used to develop and implement regulations, protocols, compliance reviews, and to investigate complaints. And happy to answer any questions.
Department of Finance? LAO? I think this one. No, this one makes sense also, Dr. Pan?
I just, again, appreciate the proposal. I do want to acknowledge, even though in the analysis, it was a committee bill, like our health, in that we included a provision, these provisions relate to Senator Bates. So I want to recognize that this was Senator Bates' implementation, and certainly happy to have to see this move forward. Thank you.
Thank you very much. All right, and I think that concludes the items that we've been talking to. We certainly, we're going to go to public comments now, but we certainly thank you for all the time that you put in both today as well as all year long and in preparation for this. Also to the Department of Finance and LAO, we appreciate your hard work. If we could now, we're going to, again, hold everything open for now, but we're going to move to anyone waiting to provide public comment. And as a reminder, today's participant number is 844-291-6364, and the access code is 1417609. Due to time constraints, I'm going to ask callers to please keep your call to 1 minute. Identify yourself, and then we'll go on 1 minute, and then we'll be moving on. Are there any witnesses in the hearing room? I see none. Okay. And then now we'll move to the teleconference line. First caller, please.
As a reminder, if you wish to make public comment, please press 1 followed by 0. And you will also want to mute your webcast while your phone line is open. Madam Chair, are you ready for the first comment?
I'm ready.
Thank you. We'll go to line 28. 28, please go ahead.
Thank you. Ryan Spencer on behalf of OCHIN and the California Telehealth Network regarding issue number 8. OCHIN's network of community clinics includes 32 California members, serving nearly 1.5 million network patients, half of those receiving care under Medi-Cal. In 2020, organizations within the OCHIN network received over 2.8 million unique visits to California, and as a result, direct result of the telehealth flexibilities and expansion throughout 2020, 37% of those encounters were conducted using telehealth, the majority in primary care services. Telehealth has been essential to advancing healthcare equity. For example, approximately 47% of OCHIN's California network patients are Hispanic, and 31% are over 50 years of age. Of these patients' encounters, 45% were delivered in a language other than English, with 3 out of 4 patients served in Spanish. OCHIN strongly supports continuing the telehealth flexibilities, particularly ensuring payment parity in all settings, including FQHCs. Especially crucial is parity for audio-only appointments, since about 26% of OCHIN's telehealth visits were audio-only, most of which were behavioral health services. Bottom line, individuals who face access barriers to in-person care have been able to receive care via telehealth during COVID-19. Patients who stated they needed housing and transportation support were 14% and 17% more likely to use telehealth, respectively. The continuation of parity and expanded telehealth coverage, including audio and services from FQHCs, is essential in order to maintain access to care for high-risk and rural patients throughout the state and help many others overcome common healthcare barriers such as work, transportation, childcare beyond the pandemic. Thank you for your time.
Thank you very much. Next caller, please. Please try to limit your comments to 1 minute.
We'll go to line 1616. Your line is open.
Madam Chair and members, it's Roxanne Gould. In the interest of time, I'm calling representing the American Nurses Association of California and the California Association of Clinical Nurse Specialists in support of item number 9.
Thank you very much. Next caller, please.
Line 4040, your line is open.
Hello, Madam Chair and Senators. This is MJ Diaz on behalf of SCIU California, here to share quick comments on the administration's CalAIM behavioral health and telehealth proposal. First, on CalAIM, we appreciate some of the slight changes in the second proposal, ensuring that there is level of continuity by requiring managed care plans to contract to county whole person care providers. But we would still like to emphasize the role of our county workers, especially their skills and knowledge of locally available resources to make timely and direct referrals connecting people to critical services. We still have a lot of questions on the managed care plan's abilities to either provide these services in-house or who they end up contracting out to as ECM lead care managers in the future. Second, on the behavioral health set of investments, we generally support the $750 million investment as well as the $389 million investment on student mental health. Although for the $750 million, we'd like to also request that this funding could be used towards improving and upgrading existing IT systems in our behavioral health delivery system in order to build out linkages for data so that we actually know what beds are available and what related services are provided or could be provided by hospitals and psychiatric facilities. And lastly, on telehealth, we are also generally supportive of expanded access to care, but want to make sure that this is additive and it would not hopefully impact or eliminate existing workforces. Thank you.
Thank you very much. Next caller, please.
Line 5959, your line is open.
Thank you, Madam Chair and members. This is Sarah McDade-Ping on behalf of the California State Association of Counties. I'm going to run through. There's 5 issues that we were monitoring today, and we appreciate your time on all of these. We appreciate on issue 2 the COVID response for DHCS. We appreciate that DHCS has turned on a dime, a veritable dime, throughout this entire pandemic, and just the partnership has been great thus far, and that's something that I haven't been able to say for a long time. So wanted to make sure that the committee was aware of that. On issue 5, CalAIM, we're broadly supportive of the whole CalAIM effort. Of course, the devil will be in the details, including how plans plan to outreach to members or prospective members. So again, we're working closely with DHCS and our affiliate partners in that area. On issue 16, the behavioral health, the governor's proposal for investing $750 million into the behavioral health housing continuum. We're strongly supportive of that issue. We also are supportive of issue 18, which is the MHSA flexibility. And we are pleased to support issue 20, Madam Chair, the implementation of AB 1976 with some additional staff for DHCS to help with that workload. And lastly, 2 issues that came up during the hearing but weren't on the agenda, the quality improvement funding that Ms. Cooper mentioned. For counties to get better data to better track outcomes. We're strongly supportive of that. And then we're supportive of the OIG recoupment. You heard from Department of Finance, Ms. Ramos, talking about the recoupment. We have asked that the state defer that recoupment for the current year and are in talks, of course, with the administration and others about that.
Okay.
Again, I want to thank this committee on behalf of all 58 of California's counties.
Okay.
Thank you.
Thank you. Thank you. Next witness.
Line 6161, please go ahead.
Good afternoon. This is Kelly Brooks. I will be commenting on 4 proposals on behalf of 4 different clients. First, on CalAIM, I'm testifying on behalf of the California Association of Public Hospitals and Health Systems, the County Health Executives Association of California, and the Urban County Caucus. CalAIM is critical for the public health care system and counties leading whole person care pilots under the 1115 waiver. As the pilots come to an end, CalAIM proposes to sustain and expand upon the important whole person care management and wraparound services by incorporating them into Medi-Cal managed care. Adequate financing and robust collaboration between public hospital systems, counties, and managed care plans will be essential to ensure a smooth transition. COVID has underscored the critical role that counties and public hospital systems have in serving the most vulnerable, and that value should be leveraged under CalAIM. Lastly, the timeline is incredibly ambitious. We must closely monitor local implementation readiness and adapt as needed. Second, on the issue related to telehealth, I'm testifying on behalf of the California Association of Public Hospitals and Health Systems. Telehealth has been absolutely critical for public healthcare systems during the pandemic. Many patients have come to prefer connecting with their providers via telehealth, and that will still be true post-pandemic. Video visits are not a viable option for many of our patients, so audio-only phone visits have been a critical modality, and we must continue to allow in the Medi-Cal program to ensure equitable access to care. Phone visits can be a good substitute for certain types of in-person visits, and when the same standards of care are met, we believe payment should be the same as if it had been in person. We look forward to continuing to work with the department on this important access point for patients. Next, in regards to the $750 million proposal for behavioral health infrastructure, both the urban counties of California and Riverside County support that proposal. And finally, on behalf of Riverside County, I wanted to mention they are looking very closely at the student behavioral health proposal that received a lot of conversation this afternoon, and trying to figure out how that proposal complements some of the existing work that is going on between school districts and county behavioral health. And we look forward to receiving more information in detail. Thank you.
I appreciate it. Oh, thank you.
Thank you very much. Next caller, please.
Line 6363, please go ahead.
Hi, thank you, Madam Chair and members. Kathy Sunderling McDonald for the County Welfare Directors Association. First, I'd like